Bismillahirrahmanirrahim. We are going to carry on from where we have left in the previous part of the video. RH factor. Previously, we have studied about ABO blood group system. Now we are going to discuss what is RH factor. RH is just like A antigen and B antigen. It's also an antigen that is present on the surface of the RBCs. It was discovered by Landsteiner and Weiner. It was first discovered in a monkey known as rhesus monkey, and that's why it was known as Rh factor. There are many Rh antigens, but the only D antigen is more antigenic in human. Um, the persons having D antigen are called as Rh positive, whereas the persons which have no D antigen in them are known as Rh negative. So Rh positive individuals and Rh negative individuals. That's why you are known with blood group A negative or positive, B negative or positive, ABO negative, AB negative, AB positive, O negative, O positive. So, but in this type of blood group, we have no risk of complications if an Rh positive person receives the blood with an Rh negative blood person. If the transfusion reactions occur between Rh positive person and Rh negative person, what happens? What happens is that when an Rh negative person receives Rh positive blood for the first time, he is not affected much. Since reactions do not occur immediately, but the Rh antibodies develop within a month. So the antibodies are developed within a month. That's why the reaction does not occur acutely or spontaneously. The transfused RBCs, which are still present in the recipient's blood, are agglutinated. These agglutinated cells are then lysed by the macrophages of the individual's defense system. So there is a delayed transfusion reaction, and the symptoms are very mild, just like the mild symptoms of transfusion we had did previously. And they does not affect the recipient at all. However, antibodies develop and the recipients remain in the body forever. So when this person receives Rh positive blood for the second time, the donor RBCs are agglutinated and severe transfusion reaction occurs immediately. So for the first time, if the blood is transfused, nothing much happens. But it will happen eventually if the same blood is transfused for the second time. Because for the first time, when the blood is transfused and there is mismatching, the reaction does not occur quickly. The antibodies are not formed immediately. Instead of that, they're formed after a month. So after a month, the reaction is very mild, but they stay in the individual's body and wait for the next time. And if that next time happens, what happens is the transfusion reactions occur immediately and the symptoms are severe. Just what we have studied right now, there is another term based on that concept, which is known as hemolytic disease of fetus and newborn, erythroblastosis fetalis. It's a very important phenomenon, and I want you all to listen it very carefully. So, erythroblastosis fetalis, as the name indicates, this is the disease of a fetus. Um, just give me a minute. So, So as I was telling you, erythroblastosis fetalis, the name indicates this is the disease of a fetus. Erythroblastosis, erythrocytes are going to have a blast, and erythrocytes are the red blood cells. So let's see what happens in it. Hemolytic disease is a disease in fetus and newborn characterized by abnormal hemolysis of RBC. Yes, that's what's going to happen over here. There is going to be abnormal hemolysis, abnormal breakdown of RBCs, which is not scheduled normally by the body. It is due to Rh incompatibility. That is the difference between the Rh blood group of the mother and the baby. As I've told you, this is based on the phenomena we have just recently discussed. So, if the mother is Irish negative, and the fetus is Irish positive because of the father. What happens is, if the mother is negative and the fetus is Irish positive, usually the first child escapes the complications of Irish incompatibility because there is not going to be any reaction between the Irish negative mother and Irish positive fetus. That is because the Irish antigen cannot pass from the fetal blood to the mother's blood through the placental barrier. The fetal blood cannot let the Irish antigen of of the fetus pass into the mother's blood because of the placental barrier. Placental barrier is very strong. It lets all the nutrients from the mother blood to be passed into the fetus, but it does not allow those antigens which are present inside the fetus to be passed into the mother's blood. So nothing happens. But um, at the time of parturition, that is delivery, the Rh antigen from the fetal blood leak into the mother's blood because of placental detachment. When the placenta is detached, there were the antigens of fetus. So those RBCs having different Rh antigens are escaped into the mother's blood. So right after delivery, the period is known as postpartum period. In postpartum period, that is within a month after delivery, the mother develops Rh antibody in her blood. So now, because of the the Rh positive antigen of the fetus, now the Rh antibodies are developed in the mother at that in a time span of 1 month. When mother conceives for the second time, now the baby escaped and no symptoms were shown in the baby because there were no, clumping of the blood previously. But now, if the mother conceives for the second time and the fetus happens to be Rh positive again, the fetus happens to RF positive again, so the Rh antibody from the mother's blood crosses this placental barrier and enters the fetal blood. Previously, the antibodies, the antigen present in the fetus was unable to cross that placental barrier and enter in the mother's blood. This time, the antibodies has been developed because of the placenta detachment at the first time, at the first baby's time. And they stayed inside the mother's body. Now, when she conceived for the second time, those antibodies have the ability to cross the placental barrier and enter into the baby. But what baby has inside them doesn't have the capacity to cross the placental barrier. So this time, the second time, from the mother's side, the antibodies traveled inside the baby. And once those antibodies entered into the baby, which is again Rh positive, so these antibodies and antigen produced a mismatch reaction, which resulted into the hemolysis, immature hemolysis of RBCs. And that immature hemolysis of RBCs resulted into the breakdown of hemoglobin and iron into the blood of the baby. Rh antibody which enters the fetus causes agglutination of fetus RBC resulting in hemolysis. So where hemolysis in fetus causes jaundice, the first feature that will appear in the baby is jaundice. To compensate the hemolysis of more and more number of RBCs, there is rapid production of RBCs not only from the bone marrow but also from the spleen and liver. Now, many large and immature cells in pro-erythroblastic stage are released into the circulation. So you see, just to compensate the phenomena of the hemolysis of immature RBCs, uh, the more and more number of new RBCs are produced, and those RBCs are in the pro-erythroblastic stage and are not mature, and the body does not wait for those RBCs to be in the mature stage. Instead, they release them in the pro-erythroblastic stage, which are the immature RBCs. They are released into the circulation. Because of that, because of those pro-erythroblastic RBCs, immature RBCs, what happens in the body is severe anemia, hydrops fetalis, and connectris. Now we are going to discuss what is impact of hemolysis and excessive hemolysis results in anemia. Infant dies when lungs get severe. So you know what the less amount of RBCs in the body, less amount of iron and in the body, and the infant dies in a big way. Hydrocephalus. It's a severe condition in the fetus and is characterized by edema. Edema is well because there is water, intrafluid. Severe hemolysis results in development of edema, enlargement of liver and spleen, and cardiac failure. So, because of this severe hemolysis, what happens is the development of edema, the liver enlarges in size as well as the spleen, and it results in cardiac failure, which can lead to the intrauterine death of the fetus. The fetus dies before even he is born. Then the third condition is kernicterus. Kernicterus is the form of brain damage in infants caused by the severe jaundice. Because of the severe jaundice the fetus faces, it results in the brain damage. And that brain damage is because of the high level of bilirubin content. Because the blood-brain barrier of the infants are not developed yet, and the blood-brain barrier, stops any toxins or any irrelevant substances to be entered the brain. So the infant's blood-brain barrier is not developed, and they let that bilirubin to enter into the brain part, and they damage the infant's brain. Most commonly, the affected parts are the basal ganglia, hippocampus, geniculate body, cerebellum, cranial nerve nucleus. And when they are damaged, the features they show are the when brain damage starts, baby can become the lethargic and sleepy. Lethargic is lazy, having a hypotonic body, and sleepy. High pitched cry, hypotonia, and arcing of head backwards. As the disease progresses, they develop hypertonia and episthotones. These are the movement-based terms. You just need to learn them for right now. Advanced signs of these diseases are inability to suckle the milk. The baby won't be able to suck the milk to have the milk through sucking, irritability, and crying. The bicycling movements will increase. Polioathetosis, again, this term is a movement-based term. Spasticity, seizures, fever, and coma. So these were the conditions. These were the terms for the which complications of erythroblastosis fetalis. How are you going to prevent to treat erythroblastosis fetalis? If blood is found to be Rh negative and the fetus is Rh positive, anti-D antibody against D antigen should be administered to the mother at the 28th or 34th week of gestation, as stated Maya. Before, what is a prophylactic Maya? Prophylactic Maya is you give a medicine to a patient. Following disease is going to happen in the future. You give the medicine to that before even that condition or disease has been started. You medication on that specific condition. So before erythroblastosis fetalis occur as a prophylactic measure, what you do, you give the anti-D in at the 28th to 34th week of gestation, and if Rh mother delivers Rh positive baby, then anti-D should be administered to the mother within 48 hours of delivery. So if the delivery happens and the baby is Rh positive, what you do, you will administer anti-D within 48 hours of delivery. So you can either give it before, between 28th to 34th week of gestation, or you can give it right after the 48 hours of delivery. If the baby is born with erythroblastosis fetalis, treatment is given by means of exchange of transfusion. So in that case, you need to transfuse that. So let's revise erythroblastosis fetalis. It's a very simple phenomena in which the mother is Rh negative and the baby is Rh positive. For the first time, nothing happens because the whatever is inside the fetus cannot be passed into the mother's blood through the placental barrier. But at the time of the delivery, parturition, when you detach the placenta, some of the fetus blood leaks into the blood of the mother, and this blood is having those RBCs which have the Rh positive antigen, which react with mother's Rh negative antigens. But that reaction happens within a month. So what mother feels are the mild symptoms, the very mild symptoms, but mother's body, develop the antibodies against those antigens of fetus. But obviously, they are not going to hurt the mother's body, so they remain inside the mother's body. Mother conceives for the second time, and then again happens to be Rh uh, positive. So what happens then? The antibodies of mother can pass through the placental barrier to the to the fetus, and they when they once these antibodies enters into the fetus blood, they hemolysis of the RBC. Because of the hemolysis of RBCs, new premature RBCs are formed, and those premature RBCs and the hemolysis of normal RBCs result into the conditions known as jaundice, anemia, connectris, and the hydrocephalus. Hydrops is characterized by the edema. Connectris is characterized by the brain damage. And how you treat it? You are going to treat it with anti-D injection. If the baby is not born, then within the time span of 28 to 34th week gestation, and if the baby is born right within the 48 hours of delivery, and if the baby is born with erythroblastosis fetalis, you are going to transfuse the blood of that baby. So that was all about the erythroblastosis fetalis. With that, we are done with this chapter. Till next week. Take care of yourselves. Allah Hafiz.